All right, let's look at a few examples. Here's a little movie where we're collapsing. Looks like this is the artery here. Looks like someone's left femoral, possibly. Right here, we see the vein. It's not collapsing. We're applying a fair amount of pressure. So this is a DVT. We have a non-collapsing deep vein. We like to follow these up and down to see what the extent is. But once you find this, you have a pretty good diagnosis. You don't always see the clot within the vein, depending on how long it's been there. Another example, so this looks like probably someone's right femoral. And we see here's the artery. It's pulsing a little bit. And we're trying to collapse here. And this is another example of a DVT. So pretty straightforward. Again, once I find them, I usually do like scan up and down and see how far they go. Sometimes a question I get is, does pressing on the vein lead to embolic events? Not that I know of that's ever been reported. Obviously, if you see a clot, don't sit there and massage it a whole bunch. Do enough to make the diagnosis. It's okay to let learners look for a few scans, but don't let them spend 20 minutes on there massaging it up towards their heart and their pulmonary arteries. Another example here, that looks like it's in the popliteal fossa. Artery is deep. We can kind of see it pulsing here. And this is the main popliteal vein. This is one of the branch points, and we see some of these superficial ones up here as well. And it's, again, not collapsing. This is another DVT. So if you haven't caught on, all of my examples are positive cases, which should be the clue to show this one. Again, positive. We see the femoral artery. And here's the vein. We can even see probably a little bit of a clot in there. This is another DVT, a non-collapsing vein. And once again, that looks like popliteal, so we see the artery down deep. If the artery compresses and the vein does not, we know it's got clot in it. And this one's distended. It's got, you can see visible clot within there, so this is an obvious deep venous thrombosis. Some other clinical considerations, if they have persistent symptoms, so even those low-risk patients, low-likelihood patients, I often say, if it still hurts in a week, follow up. Maybe you'll see your regular physician for a possible repeat exam. And remember, high-likelihood patients, so a patient that's got a big purple leg, and you think they have a clot by all clinical estimations, and you don't see it, but they have a high clinical likelihood, maybe they need to get some further imaging with CT venography or MR venography or things like that. The one thing I'll say about that is patients who have big purple legs with a clot, their clot burden is generally extensive, and we're usually going to find it with point-of-care ultrasound. I don't really have great literature to back me up on that, but that's my general sense of patients I see. I don't worry too much about missing the clot in the purple leg. This is just a review of the American Institute of Ultrasound and Medicine DVT guidelines. I'm not going to read these completely, but they essentially talk about how to do the exam in the way that we've described already. I will point out they do talk about any focal symptoms, so they say, here, it hurts right here on my calf. Look at those areas as well. Don't forget those areas. Again, emphasizing that they have a focal area in their calf that they say is red, swollen, or hurts. Take a look at that area, especially if you haven't found any diagnosis in the proximal leg. So back to some of the cases that we talked about. This was our 29-year-old woman who looks pretty stable, but has some risk factors. Within about 5 minutes, we can look at this patient and say, yep, you have a DVT. And our current days of therapy, as long as there are no contraindications, we can probably start this person on direct oral anticoagulant right here, and they can go home. So popliteal DVT, what we would typically do in our department is either rivaroxaban or apixaban and send this patient home. We can have them out in probably 10 or 15 minutes. The next case, a 23-year-old female with left chest pain. However, she's pregnant, but looks pretty stable, right? Normal, pretty good pulse ox, heart rate, blood pressure. We're often hesitant to want to do CT, pulmonary angiography, and expose the fetus and the mother to all that radiation. So if in this patient, if we find a DVT in one of the legs, then we've got a rationale for therapy. We don't really need any other workup. This patient needs at least 3 months of anticoagulation and specific follow-up, but the diagnosis of venous thromboembolic disease is made, and we don't necessarily need further evidence to document if they have a pulmonary embolism or not. Now, I'll point out, it's a stable patient, not someone who's sick, hypoxic, that kind of thing. But the rationale for therapy is established if we find a clot in this pregnant patient. So our next case, a 58-year-old male who's acutely short of breath, who looks kind of sick, kind of unstable. Maybe too unstable to leave our presence to go for a CT scan. Hypoxic, hypotensive, tachycardic. This is not an echo talk, but here's the echo image that shows a dilated right ventricle. This is the left ventricle being compressed. So that gives us some evidence that this may be an acute PE. Given that clinical scenario, if they have clear lungs and that you see this on echo, pretty strong case for PE. But if you're making the decision to give this patient thrombolytics without clear 100% evidence of PE on a CT scan, it's nice to see a clot in their leg, that kind of helps add weight to your diagnosis of a probable PE, and then help you make that decision of how am I going to treat this patient and maybe consider thrombolytics. So they have RV strain, they have a DVT. This supports a decision, assuming there are no contraindications, to administer systemic thrombolytic therapy. Next one, 62-year-old female, acutely short of breath. Vitals don't look so bad, but a little hypoxic, not super unstable, but there's reasons they can't go for an immediate CT pulmonary angiogram. Again, echo video, not the point here, but we see, again, dilated right ventricle, compressed left ventricle, not a definitive, but increases the likelihood that their dyspnea is due to an acute PE. If we find a DVT somewhere in an arm or a leg, then that gives further weight and clarity to that diagnosis to help us make treatment decisions. And again, this would support the decision to administer TPA in this patient with a heart rate greater than systolic blood pressure and hypoxic respiratory failure. Again, not going to debate TPA or not, that's beyond our discussion today, but these findings would support that decision without a definitive CT-confirmed diagnosis of pulmonary embolism. Back to that algorithm. If they have a low likelihood of DVT and you do a quality point-of-care ultrasound and it's negative, you're done. Now, I always tell the patients, if it still hurts a week from now, seek further evaluation. If they're moderate or high likelihood for DVT and you have a negative quality point-of-care ultrasound, they need a repeat in about a week. Quick summary on the lower extremity. It's quick, it's easy, it's done well, it's accurate. Make sure you find the deep arteries, compress on them vertically, and decide are they collapsing or not. That's going to be it for over 95% of the patients. Assess the likelihood, make sure you see all of the junctions, follow that femoral vein down the thigh as far as you can, and then do they compress, yes or no? Those are our take-home points.